she wanted to be an independent investigator. So she got a PhD in epidemiology at not Ohio State, but the Johns Hopkins. And we were super lucky enough to have her as a postdoc fellow. So I brought her over, one of the best, easiest, obvious recruitments ever. And she's been with us since 2019. And not surprisingly, with her CV or expertise, she immediately got an NIH and an AHRQ career development on her first go round, had to turn one of them down. And so she's year 3 of 5 of a career development grant. As you'll see, she's skilled in many areas, but what she's going to talk to you about a little bit today is her career development. A little bit is on natural language processing and its ability to help predict resistant bacteria. But she's quickly pivoted as the field has moved to AI and has this amazing interplay between policy, legal, and high quality research. And so that's Katie in a small nutshell. And Dan, I think everyone on this call should know, he's a full tenured professor who joined our group in 2008. He's in charge of epidemiology and hospital epi group at the VA, so works closely with Casey and Mary Claire, and initially started his research in infection control and issues of contact precautions, and has pivoted an area to medical decision making and how to teach med students and others about pre-test and post-test probability using novel visual methods, and is really interested in, as you'll see, the use of AI relative to kind of medical decision making and help guide medical decision making. And the two of them have been very successful at navigating kind of policy documents recently, both in the New England Journal and JAMA's Viewpoints, which you'll hear. And I'm sure you want to hear more from them and less from me. So why don't we get started?
What we're talking about today is generative AI, specifically in healthcare. And we're going to talk a bit about where we are currently, where we see the field going, and probably most importantly, where academia can play a role in this changing landscape. Why is this not advancing?
Just try again.
Okay. So to start with disclosures, neither Dan nor I have any industry funding, but you will in this talk see a lot of industry screen grabs. And really that's a function of how consolidated this technology really is in the hand of a few tech companies. It's a problem, and it's something we'll talk about later, but that's why you will see a lot of industry screen grabs in this talk. And we wanted to caution, while Dan and I believe that we really have built expertise in understanding where AI is going in healthcare and how it may affect both clinical decision-making and some of the legal and policy elements as well around this new technology. We don't consider ourselves generative AI, quote unquote, experts, but I think we would caution that anyone who sells themselves as that right now, given how new this technology is, except maybe if they work at OpenAI or computer, be skeptical of that claim. But we certainly don't hold ourselves out as experts. So what we will talk about today is what is generative AI in healthcare, where we are currently and where we're going quite quickly, what we think is most exciting about these developments, but also most concerning, and then of course, where academia can play a role in this landscape. So what is generative AI, and specifically in healthcare? So there was a really nice JAMA piece probably just a few weeks ago. These authors, a collaborative group, they've called generative AI really the third epic of AI in healthcare. The first being rule-based models, the second being predictive AI and deep learning. But for our purposes, or for your purposes in today's talk, I think it's less about a definition of generative AI and really what makes it unique and different than, let's say, older predictive AI. And really the salient differences here are that generative AI can perform lots of different tasks without either new data sets or retraining. And I'm sure if you've interacted with ChatGPT online, you'll see that based on the query you put in or the prompt, you can get very different outputs. Secondly, generative AI, for the most part, can interpret and respond to complex questions. And that's very different from predictive AI and really sets it apart. For example, explain the difference between a cat and a dog. And so when you hear about large language models, that's one type or application of generative AI where the models have been trained on very large bodies of text. Normally, though not always, the output is itself a natural language-based output. And then you may also hear about large multimodal models. So they're similar to LLMs, but they can also input other types of data like images or sounds and also output them. So just to illustrate this a little bit more concretely, when we think about predictive models, and that could be logistic regression or machine learning based model or predictive AI, let's say, a deep learning, a neural network. Really, the defining feature here is that we have some set of inputs on the left, let's say patient characteristics or clinical data. And on the right, we have a predicted outcome, whether that's a probability, in this case, let's say diabetes, or it's a predicted class, diabetes, yes, no, or for example, it's been transformed into a risk score or a points-based score for diabetes. But the critical feature here is that if you were to change the inputs in the model, you would need to refit that model. And is there a problem?
Report to the main lobby.
Somebody needs to put themselves on mute.
Now departing. All scheduled passengers, please report to the main
I don't think
lobby.
that's us.
No, I'm gonna.
No, it's okay.
Okay, I thought I could
Someone will
mute it.
mute themselves.
Yeah.
Okay. And then secondly, if we wanted to predict a different outcome, let's say congestive heart failure, not diabetes, you would potentially need new data, but at a minimum, you would again need to refit this model. So generative AI is different. And this is a silly example here, but this is from ChatGPT a couple of days ago. But we can see on the left here, normally a lot of my work's in antibiotic resistant bacteria. So I've said, come up with a study name acronym for research that will investigate CRE carriage, a drug resistant bacteria in hospitalized patients, because clinical research, they love their studies that have acronyms. And so very quickly, this was in a second or two, ChatGPT outputs this lengthy text-based response, giving me a suggested acronym of high care, not terrible, and in fact, recognizing that CRE is a type of drug-resistant bacteria. Now, granted, it's been updated to carbapenem-resistant Enterobacterales instead of Enterobacteriaceae, so it's not quite right, but you get the idea. And if I were to change this prompt, and I'd say, well, that was good, but give me another one, it would give a new output. So really that helps illustrate, hopefully, the important differences of generative AI for healthcare. And we'll get to now, how do we see that play out in healthcare? So what are the current applications of generative AI in healthcare? And really here we're talking about applications that either already have been clinically deployed or are in a very advanced late stage development. And as a result, while LLMs have many different potential uses in medicine, I mean, they're being used for drug development, they're being used for imaging analysis, all these other applications. What we are focusing on today, because they're also the applications that are in most advanced development, we're really focusing more on the clinical care and clinical workflow applications. And really, LLMs have hit a sweet spot here in this Venn diagram that we made where the areas that they really have been deployed already or in advanced development and can really shine the most are where the current technology, and in particular, the electronic health record, is pretty painful to use. To interface with it and get information out of it is really cumbersome and clunky. Secondly, if it's an application that's natural language based, what's called unstructured data, like think of free text notes or free text speech. And thirdly, an area where clinical decision making or action is hampered by time or resource constraints, which is actually most unfortunately of clinical care. And so where those domains overlap is really the areas that we're seeing the current applications of clinical LLMs. So one of the first applications, and this is the one that I think probably is truly the most advanced, and we'll talk about how it's already current, is clinical communication. So many of you probably have been forced to sign up for a MyChart account when you've seen a healthcare provider. And within MyChart, you may or may not realize that there is a messaging center where you can send messages to your clinician. And really during the pandemic, the use of patient messaging and the volume of messages that physicians received and that skyrocketed, of course, because patients weren't coming in for face-to-face care. Most clinicians do not have time built into their workday to respond to patient messages. So, you know, you come back from a meeting and you see that your emails have piled up and it's stressful, and how are you going to stay on top of them? It's the same thing for most clinicians. These are things that often are dealt with in pajama time, after hours. It's often uncompensated time, but it's a leading cause of physician burden and burnout in survey after survey. And so in the spring, probably you saw this covered in the news, there was a really nice JAMA article, and it was comparing ChatGPT to physicians in responding to patient questions. Now, these were posted on a public social media forum, because we can talk about it's difficult to do these studies on actual clinical or patient data. But what they found is that without fail, by and large, you can see from these distributions, ChatGPT's responses were perceived by patients as both being higher quality and also being much more empathetic. And I want to just emphasize here, you can see the date on this study. It was April, late April of 2023. So that was a large study team that published that article. One of the authors on that study was interviewed by Epic, which is one of the leading EHR vendors in the US and is the vendor that the Maryland medical system uses, in August. And as you'll see here, he is saying that they are already using a GPT-based, well, it's generative AI. We know it's GPT-based because it's partnered with Epic, to respond to patient queries in the MyChart or the patient portal, so that it's already being used in clinical care just a few months after the publication of that JAMA article, which if anyone does anything informatics based in healthcare knows that these timelines are just absolutely insane. Nothing moves this quickly in healthcare, especially implementation into the EHR. And so this is already being used clinically at multiple sites around the country. And we know other locations where they're contemplating purchasing this as part of their Epic module. So another area that we've seen a lot of research of generative AI and the large language models is for patient diagnosis. And here we're not talking about diagnosis from a radiological image, but the true face-to-face type, normally historically face-to-face patient diagnosis. And diagnosis is ultimately a complex, what we call piecing together of patient history, signs and symptoms, laboratory and other results, many other different data types. And as Dan has said, diagnosis is really considered like the art of medicine as much as it is a science, right?
Yeah, people have largely, I think, it's been too complex to really describe that well. And people have tried over time. And in this study that they're looking at, took the hardest cases, sort of like the best artists who, were doing these very difficult cases in the New England Journal, for which most of us average doctors would not get the answer right.
Yeah, so this is an example here. New England Journal publishes these complex diagnostic challenges, and you're only seeing a snippet here, but they're multi-pages long, and then physicians try to come up with the answer. So collaborators that we have worked with from Harvard and Beth Israel Deaconess up in Boston, they pitted GPT-4. They gave it 70 of these complex diagnostic challenges from the New England Journal of Medicine in the spring. And what they found is that even this, general GPT-4 model, which they gave it a couple examples of the right answer to learn from, but otherwise did no further fine tuning, that it got the single correct diagnosis in 64% of those 70 cases, which Dan has said exceeds most expert diagnosticians. And so that was pretty staggering. Nevertheless, though, only a couple of months later, this was just released in preprint, Google has developed another large language based model. And what they did here was they took it one step further. And this is actually evaluating their model, an LLM, in an interactive diagnostic process. And so they took patient actors with standardized scripts, diagnostic scripts, and had them interact by text. So you with either a real physician or the LLM, it was blinded, and then did effectively like a diagnostic interview and work up to arrive at a diagnosis, and evaluated the output of both physicians and the LLM on multiple domains. And you can see these domains at the top of the screen here, this sort of hexagon shape. And what we can see is that the LLM called Amy, which is in red, outperformed physicians in all of the domains they evaluate, but in particular in empathy, but also even in, you know, this top 3 diagnostic accuracy. And what we see on the bottom is that this is having the top 3 diagnoses in your differential diagnosis, and that here again, the LLM outperformed human physicians. And so just to say that these things are developing very, very quickly, and we'll see what comes down the pipeline in a couple months. Okay, let me get back here. Okay, so finally here, one last use case that we wanted to talk about, and you'll hear a couple slides from now. Also, I mean, this is an area Dan and I are particularly interested in, or maybe I've pulled Dan kicking and screaming into this area, but is clinical summarization. And so, as we mentioned previously, lots and lots of patient information lives in the EHR. In terms of using that information for clinical decision-making and care, it is only as good as the way in which it's presented to physicians and the way that they can extract it from the EHR for real-time decision-making. And the EHR is really poorly set up for that. And so where we see LLMs are already being used and will be used is in summarizing both patient interactions and then also clinical information. And so this is just a short example. I'm going to skip to the relevant parts, but to illustrate a product that is already on the market, and a similar one is being actually piloted right now at Maryland in some outpatient clinics, that creates LLM generated summaries of patient interactions. So let's just skip to the relevant bit. So about right here.
Ask George if it's okay to start recording. After that, it's a completely natural experience. So the DAX mobile is then put down. Physicians' eyes are free to make eye-to-eye contact. Hands are free as well. Physicians no longer burdened by having to take notes in real time, having to remember any details of the conversation. Fundamentally, what we're attempting to do here is bring joy back to the practice of medicine for physicians worldwide. This patient happens to have presented with complaints of something called chronic fatigue. So this could be super simple, like you need to get a little bit more sleep, but it could be super complex and could be an advanced disease state. So these transcripts can be super long and involved, cover a ton of territory. A 10-minute encounter can literally produce several pages of transcript. Then when the episode is complete, generative AI takes over again, and then within seconds, this transcript is turned into clinical documentation. This is, for lack of a better description, it's called a SOAP note, subjective, objective, assessment, and plan. It's basically clinical documentation formatting. All the relevant details are captured and the irrelevant details are ignored. So what you...
Okay, so you get the idea. It's an audio records the entire interaction from a phone even, generates a transcript immediately, and then creates that LLM generated summary. And I sort of love, I say facetiously, as he says, you know, all the irrelevant information is excluded in this summary and only the relevant details are included. Well, right now, no one is at the helm of that ship really deciding what counts as relevant and irrelevant, which concerns us. We'll talk about, but if this video continued, then in fact, the doctor with voice commands can edit certain parts of the note and then say, send it to the EHR. So, and this is a tool that is already clinically available. Okay, so you've seen a bit about where we are currently or going very quickly. And we wanted to take a couple minutes to talk about, and some of this has been obvious already, but maybe not the concerning part of what do we think is most exciting about the potential of generative AI in healthcare and in these clinical workflow applications, but also what do we believe is most concerning? So we'll start with the good parts. The exciting parts, as sort of even that Microsoft video suggested, is, you know, as we've now said multiple times, the EHR is really poorly designed. It was designed primarily for billing and clinical documentation, but really not for supporting good clinical care. It's clunky, it contributes to physician burnout, and there are lots of every year medical errors that result from mistakes that happen in terms of physicians interfacing with the EHR. So for example, here, this was an analysis of over 400,000 medical malpractice claims. And you can imagine that, you know, the amount of problems that actually get recognized and then rise to the level of being the basis of a malpractice claim, it's an iceberg. There's so many below the surface we don't even know about, but just to show that EHR related factors do comprise about 1% in this case of, or 0.1% of medical malpractice claims, with user error being a leading contributor, and then, or incorrect information in the record or copy and paste errors. And that most or predominantly the types of EHR related issues, the errors that result are in diagnosis. And that's an area that's particularly near and dear to Dan, and we'll talk about more of how that LLMs might improve this process. So in that regard, we are really excited about the potential for generative AI to improve both, you know, most importantly, clinical outcomes and patient safety, to reduce these EHR related errors, but then also to reduce clinician burden and burnout, which we mentioned lots of physicians, they're leaving the profession. They consistently cite the EHR as one of the leading causes of their stress levels and burnout. And there are real ways that this could help make this better. Okay, but of course, then there's always the flip side, right? So that's the good part, but the things that concern us, and in particular me. So one of them are, we believe we are currently operating in a real regulatory void or gap here. So when we think about LLMs for analyzing, let's say, radiological imaging, finding breast cancer on a mammogram image, those things, I don't know the quality of it, but they will be legally, they are regulated as medical devices by the FDA. But there's this whole world of software that acts as a clinical decision support tool, like the things that we have been talking about in these slides, that is much more nebulous. And FDA was concerned that lots of different informatics tools in the EHR could impact patient safety, but were not being regulated as devices. And so in November or September of 2022, you'll see this date here, they released final guidance, which final guidance is basically illustrates how FDA interprets laws and regulations and intends to exercise their regulatory authority. And what they said was basically all these different CDS tools, a lot of them we are going to consider medical devices, and you'll have to, on some level, prove their safety and efficacy. And we wrote a piece about this at the time, actually thinking they took too broad a stance. But nevertheless, unfortunately for them, they didn't have a crystal ball. It's not their fault, but they couldn't see into the future. And only 2 months later, ChatGPT was publicly released. And why this is a problem is, you know, FDA was really thorough in this guidance of talking about what are the different criteria that will pull something in as a medical device. And I only call your attention to this yellow box here, that basically one of the core hooks is that it's outputting either a risk score for a disease or condition or a probability of disease or condition. And that is really well suited to a predictive model or predictive AI, and it is really poorly suited to natural language-based outputs or clinical summaries or these other types of outputs that are really the core outputs of a generative AI model. And so by FDA's own terms, a lot of these applications would not clearly fit into their medical device regulatory framework rather. So secondly, you know, we have this landscape where a lot of these tools, you know, some of them already are clinically deployed or are coming quickly, potentially without FDA oversight. And then secondly, we have a real reason to believe that there's going to be enthusiastic clinical uptake once they are implemented in the EHR. And that concerns us because there are certain human biases that these tools play into. So all AI, including predictive AI, we've known about, and FDA has been very concerned for a long time about what's called automation bias, that there's this human tendency to over-rely on automated information. That is still potentially a risk with generative AI too, but it also introduces these additional human biases that really aren't as much at issue with predictive AI. And one of them, which we sort of called the Amazon bias, you know, that's not a term of art, that's just what we're calling it. But it's this idea that these tools will be really streamlined into the EHR. They will make clinicians' jobs easier, not harder. Whereas predictive AI, you know, you deploy an algorithm, it's a pop-up alert or a warning in the EHR. Most clinicians say they're really annoying. They just want to click out of them. They don't like them. They don't want to use them. We think that clinicians really will want to use these tools and therefore may over rely on them. Secondly, there's this idea of this anthropomorphism bias or familiarity bias, where because the outputs are natural language based, they seem human-like and can sound deceptively cogent. And so you may be getting nudged and it's a lot harder to realize it compared to if the output was like a probability or a risk score. And so these are things we definitely think should be on everyone's radar. So allied to that, then putting those pieces all together, we were really fortunate to have a piece published earlier this week, a viewpoint that was trying to highlight specifically for clinical summaries, how they could escape FDA oversight, but that there's these other elements that go into creating a high quality summary beyond just accuracy. And that's really where the field is focused to date. That of course we know these summaries should be accurate, but we are trying to highlight that there's other important features of a good summary we need to be aware of and we need to be looking for, even if it's not regulators, but third-party standard setters. And so we highlighted a couple of these issues. I won't belabor them here, but just one of them to highlight in case you're not as familiar with how these models work is this thing called sycophancy bias. And so what we did in the example is we fed ChatGPT real discharge summaries that were de-identified from a public database. And so these discharge summaries are multi-pages long. They have tons of data, and that you would never as a clinician in real time be reading that prior. Let's say you have a patient in the ED and we said here, presenting with, let's say, chest pain and shortness of breath. And you want to know, well, were they seen in the last 6 months in this hospital? What was their discharge summary that summarized their recent clinical course? And what we found is that if you changed your prompt to say that there was a suspicion of, let's say, heart attack or MI versus pneumonia, and that you actually got a different summary out that emphasized either the cardiac history or the infection history of the patient. Neither of these summaries are wrong, but they could influence clinical decision-making, almost a form of confirmation bias. And we really feel that right now, to our knowledge, a lot of places as they're developing standard and rolling out these summaries aren't thinking or looking at these other domains. Okay, I'm gonna switch over to Dan now, give my mouth a rest, and I'll be back at the end.
All right. Great. This has been a joy to work with Katie on these different projects and even putting this talk together. I think it's been educational for me. So, I mean, I'm normally a skeptic and kind of, I'm a late adopter of technology, but I do think that LLMs and this type of technology really seems like it will become pretty central to clinical medicine. So for that reason, it has attracted my attention, I guess. Because I think, it really is like a big part of how we're going to interact with, it's like the EHR, but it's going to do a lot more. It's going to be how doctors respond to patient questions, as Katie talked about, how doctors document care, how billing occurs, how insurers try to deny billing. There's already LLMs going back and forth on justifications, how chart information is retrieved with this summarization. So essentially, people may not be opening the chart and trying to fish through and find the notes or the laboratory values for certain days if you can just ask the computer to do this, in a much more sort of Star Trek-y feel to it, talking to the computer for information versus clicking around on a chart. And ultimately, I think it will be slower because there's, the FDA and probably other groups will be doing oversight of this, but it will really guide diagnosis and treatment. So all these, I think, will change how care is delivered. So that will impact, clinicians in clinical medicine, but also will impact how we collect data, which will be key for research. Just, and I don't know exactly how this is going to influence those things, but it seems like things will be pretty different in the coming years. And as Katie said, this, all the large players are very interested in this. Epic, who controls, the majority of electronic health records. Microsoft, that has a lot of health data, and then Google, which I think they're trying to figure out a way in, but all have been pouring money into this. So I'm going to talk a little bit about what this means for academia and how can we play a meaningful role. And so I guess one of the projects that got me started on thinking about this with Katie was we were very interested in clinical decision support and how those tools were sort of built into to clinical medicine, knowing that they often aren't really used that well by clinicians. And so we'd argued that clinicians need to be trained. They need to learn how machines work so that they can interact better with them. And a big part of this is that they needed to learn probabilistic clinical reasoning so they could understand sort of like what is the input going into this and the output often from these traditional clinical decision support tools, which is still sort of what's behind the scenes in these LLMs, but it's hard to get them to actually give you a percent estimate without really kind of forcing them to do that. And so like teaching clinicians and trainees is really a key way to do this. So, trying to teach medical students this, teach this as part of clinical reasoning, and then trying to work on curricula that will get people thinking in these ways so that they'll have a better sense of how machines work and where machines may miss things or may not have information that would be relevant to making the right diagnosis, and trying to figure out where clinicians fit into this well. I think that this has been a little bit different from a lot of the training that people are sort of promoting around large language models. This was something that came out last week, and a beautiful review that I learned about some of the different large language models that are out there. You can see Google, OpenAI, which is Microsoft, and other groups have these different LLMs, and so it's interesting how they're made. But I think this is a little bit like learning how an MRI works. Like ultimately, it doesn't matter if I know how the magnetic field changes and how the images are collected. What I'm really interested in is just how it impacts my ability to care for patients. I really care about the output. And I think that ultimately the clinical education, and part of this will be the clinical evidence that we will need and we don't have right now, is really kind of standard clinical research, that you have some kind of situation like patients at admission or a specific diagnosis, and then you apply an LLM to do something. So as a tool, probably with some pretty specific parameters that guide how it does this, like how the prompts are used, or not really available as options, and there's only one way to do it. And then looking at how that changes patient outcomes, because we know that it's not just sort of being accurate, as Katie's talked about, but really how does that change the care that's delivered to patients? And we know that clinicians seem to indicate that they will change their care quite a bit based upon what the computer output is for them. And we want to know, is that sort of for better or for worse? And we really need clinical studies to look at that, not just kind of hypothetical kind of like logic trees that could come out of this. So in this piece that came out last year, sort of just right at the beginning of ChatGPT, we talked about how this is a lot like diagnosis, that ultimately diagnosis is taught by evidence-based medicine is an exercise in probability, and estimating the probability of a disease when you first see a patient based upon their history and physical, and then ordering tests and then interpreting those test results to change the probability. And that clinical decision support, and ultimately AI should be, I think thought of as this, like should change that probability some, but there's, always external factors, and that this could, is sort of a repetitive process that you don't often stop with just one piece of information. But I think that's often not how clinicians are trained to think about diagnosis alone, much less about how to interact with machines. So we do think education is one place where this could be used. Currently I'm trying to revise the medical student course on medical decision making, which I do for 45 minutes once a year. And trying to figure out, like, do I do 2 slides or 3 slides on AI and algorithms? So there's not a lot that happens for medical students at the moment. But, I think ultimately trying to design a curriculum, which is similar to what we did for testing wisely on diagnosis and medical decision making around that, with the idea of a flipped classroom. So having video lectures at home that can kind of be optimized, just made once and then used by many people. And then game-based training could be a way of practicing some skills, but then use the in-person time more for discussion than to passively sort of receive a lecture. So here's what we did with Testing Wisely that I think could be an example for this. Having some short animated videos. These are like sort of 3 to 5 minutes long, and we have, I think, 6 of them. And then we have a game that you can play that gives you patient scenarios. And I think, a little bit too focused on numbers maybe, but trying to focus on, people learning the skills of how to adjust probability based upon where a patient starts, the validity of a medical test, like the sensitivity and specificity, and then how you would adjust that, and then getting feedback on that in this decision tree type natural frequency analysis that seems to aid understanding of how to get the right answer. So that's one thought. Another thought is just talking about how clinicians will learn to interact with these. So this was a commentary we put together after that New England Journal piece that was trying to sort of translate the meaning a little bit more to like what AI will mean for doctors, and ended up in the Baltimore Sun. And I think really the key point here, just in the interest of time, is that we think that these AI technologies should be thought of much more like partners and not as sort of like a tool or a program that's used. That these will probably become so kind of ingrained into what people do, and they're so complex that they do a lot of things, and they can be pretty good at a lot of things, and they almost feel kind of human too by their ability with language. That we need to think about them a little bit more as partners than as a tool for one specific problem, and knowing that they're going to have weaknesses that we need to be aware of so that we can provide better patient care. And so one example of trying to look at how well they did, that was a project we did that was published this last year, was we had a big database on how well doctors do in estimating probability. And we had simple scenarios that we asked doctors. Sorry, I'm not getting choked up on the subject. So we asked very simple scenarios. So like say a 43-year-old premenopausal woman with atypical chest pain and a normal ECG, no risk factors, how likely is she to have a cardiac ischemia? And how much does a stress test, a stress ECG test, modify that if it's positive or negative? So we knew this would be a problem for doctors because they're not used to thinking about probabilities. The results that we found, hopefully not too small here, but you can see this as a density plot. So it shows you where people's answers were in the gray, showing that people thought it was, generally, I think the median answer is about 10 to 15%. And the actual answer is in orange, and this was based upon the literature. That's probably about 1 to 3 or 4%. So they overestimated the pretest probability a lot. After a positive test result, they vastly overestimated the probability with a median of 75%. When you can see that the more evidence-based approach would yield an estimate of 2 to 10%. And then a negative result, they made their probability a bit lower, but not that dramatically from where they started, even though it should be much lower. There's a green line that's almost hard to see, but it's about 1%. So we don't do well as clinicians, as humans, with low probability situations that are quite common in medicine, and trying to quantify that probability. So we decided to ask ChatGPT-4 these same questions, and this is what it showed. So the orange is going to be from the LLM, which is GPT-4. And you can see on that same question, the pretest probability, that the LLM actually did better than the gray, right, which is the human clinician answer. So it did a better job of estimating pretest probability, and it looks like it's relatively accurate. Interestingly enough, if you ask ChatGPT the same question 100 times, you get different answers. And you can control some of that stochasticity, but not all of it. So it's a little bit like asking people things. It's the same question on different days. There's some variability. And then also, if after a positive test result, it overestimated the probability, but probably a little bit better than humans, or somewhere around the average clinician. And then after a positive test result, or after a negative test result, it did about as well as humans. So this just to illustrate that just an untrained model like GPT-4 actually did pretty well at estimating probability. It did better than the average primary care clinician on pretest probability, and then about similar for after a test result, which just illustrates the potential they have to help with this common task in clinical medicine. So, I think this raises the question, can LLMs be optimized for diagnostic support? I mean, I think that a lot of the studies now, it's kind of amazing that you can just run things through GPT-4 and then publish it. Obviously, things are going to be much more specific to medical trained things and LLMs that are behind a firewall. and there'll be a lot more data that they're working with than just sort of whatever you input, which is, de-identified, and you don't need to worry about privacy. That they'll have access to the entire electronic health record for a patient. So there's a lot of potential. And LLMs can be trained some, even with the prompting you can do. You can basically show them how to make decisions with this few shot approach. And and it could perform well over many diseases, although we need to think about how we validate that, or how well we are able to know how well it works. And probably a big part of this is looking at LLMs operating behind a firewall, which is where a lot of hospitals are going. And Katie will talk about this, but an LLM which is actually able to access all of a patient's record, even for research, gives you a very different feel than what you can input into ChatGPT, with restrictions around what's safe to put into the GPT for. So academic research, let me switch over to Katie. Maybe I'll just be your slide.
Okay, sure. So in the last couple of minutes, really quickly, just going to touch on how really where I think academia needs to go in terms of research to remain competitive. So I think first and foremost, everything of our recommendation flows from the fact that generative AI is going to change, I believe, academia's role in this landscape. So what you see here is really historically what we've been working on to date is in somewhat predictive AI, but really clinical algorithms, or let's say risk scores or risk models, logistic regression based. The ecosystem there is that researchers really have lived at the bottom of this arrow. So primarily it's been researchers and clinicians that have developed these models. They have the data sets, they have the specifically curated outcomes. So it's academic researchers and guideline setting committees that have developed these algorithms and predictive models. Then if you're lucky, you can implement them either through like national standards, or you can beg Epic to let you trial, implementing it in the EHR and deploying it. And then maybe you'll end up at the top of that arrow with commercialization. Okay, next slide. Okay, but generative AI and large language models, I believe, are going to flip this on its head. So we're going to go from a bottom-up approach to a top-down approach. As you've already seen, we're already at the point of commercialization and the industry partnerships starting first. So I didn't mention it explicitly earlier, but why we've seen these tools already being piloted and deployed in Epic is because Epic very strategically, early on last spring, partnered with Microsoft, who had partnered with OpenAI, so that they are running state-of-the-art GPT-4, and I'm sure even more advanced than that now, models within their Epic environment. So that's why things have been able to develop so quickly. So those partnerships are already happening, and researchers and in academia, we can only see what's published. If you're not in industry, you don't actually know what's going on. We're seeing internal development and rapid deployment. And then I really think that means that if we're thinking of where academic medicine and research can play a role, it's going to become more analogous to the drug development model for academia. So, that's where drug companies and industry develop their product. Maybe they'll partner with academia to do some of the clinical trials or testing, but really a lot of academic research is happening, in the clinical trials, but also in the sort of post-marketing surveillance, the observational research, that sort of landscape. And I think that's where a lot of academic research will have to move to add value and sort of add novelty. And so finally, then on our last slide, with about 2 minutes to spare, ultimately then, what does not only academia need, but I think specifically our School of Medicine, if we were trying to remain competitive in this landscape and push out high quality, good research on generative AI. Dan already mentioned this. First and foremost, we need a large language model like a GPT-4 API operating behind the EHR firewall. This is not actually that difficult to do or expensive, especially Microsoft institutions like we are. So lots of places like listed here already have these running, or they're about to deploy them. Again, this is not for clinical care, it's for research, but it means you can actually test these models and evaluate them on the real clinical data, which is inherently messy. To avoid this to date, like our JAMA viewpoint, we had to use public discharge summaries that we then further manipulated and de-identified, but that's that's not sustainable to do large, high quality studies. And then secondly, this needs to be paired with what we and others have called an AI playground, that if you can be evaluating models on real clinical data, you're also then able to bring in, let's say, the legal and the ethical expertise, and they're all under one roof, looking at the same outputs and evaluating, okay, where do we think this pushes the boundaries or not? You're not talking in abstractions. And why this is critical is, HHS, Health and Human Services, just released like 2 weeks ago, a new rule that may actually require EHR embedded AI to have oversight and have to, demonstrate that it's fair, it's effective, but they've left to third parties and academia to decide what those standards actually should be. So there's really an important opening here, I think, for scholars and academic researchers to help set those standards in a concrete way. But you need the LLM to be able to do it.
Yeah, and I should mention, Katie is going to be an expert consulting with a VA group, which is doing this too, because the VA is trying to have a nationwide plan for AI.
Dan as well.
I am too, but Katie's the expertise they wanted. I think I helped bring Katie along. But that is the end of our content. But we have to have a New Yorker cartoon.
Yeah, obviously. No. Anyway, all of which is to say, yeah, this one resonated with me. I mean, I think modern healthcare, and especially the EHR and documentation, it's painful for patients, it's painful for physicians, and so we do think there is really a lot of potential and promise here. We're really excited about, but of course, only if implemented sensibly and safely.
All right. Well, thanks everyone. I'm going to stop the share just so we can more easily see you, and we're happy to talk with anyone here. And thanks for your time. And Jennifer, I see your hand raised. You could just yell through the wall, but
yeah, I know. I could actually hear you guys talking from over there and through my computer. So thanks. Super interesting presentation. And I guess this might be maybe a naive question, but I don't think you mentioned it. And I'm just wondering, about all of these models, what's the data they're being trained on? And are they being trained on all of the data, or is there information that's behind paywalls, for example, or behind copyright laws that they don't have access to? And I'm just wondering how that could affect, their accuracy, I guess, for clinical use.
So I can take it first. So yeah, so like, let's say GPT-4, like the large language models or ChatGPT, they're what's called foundational models. So they're trained basically on most, if not all, but clearly close to all of the text that lives on the internet through, I think, like May 2021, including lots of copyrighted works. And that's a huge case right now. New York Times just, whether that's a fair use, I won't bore everyone with copyright law, but so they're trained on general, they're not trained specifically on, let's say, medical documents, but these models are so sophisticated, that we saw even this foundational GPT model not tuned for medical applications still performed pretty well at clinical summarization. But behind the firewall, like Epic is definitely tuning its version of GPT-4 on EHR notes and data specifically. And it has a couple of sites it's partnered with, like Mayo Clinic and Stanford and others. And so I think this comes up a lot in clinical medicine of, well, that's academic medical center data. Is that really generalizable, or it representative of all clinical care around the US? No, probably not. But that is the type, I don't know if that answers your question, but that's the type of data that these are being trained on.
And I would say, I think there's a little bit like, when doctors start talking about pathophysiology and like, what drug we need for someone's heart failure and alpha and beta blockers. And like, in some ways, like, I don't really care. I want clinical data to say like, how well does it work? Like not theoretically, how well should it work? Like if it had all of PubMed, is it better than New York Times? Who knows? But what really matters, I think, is like, the output that it gives for clinical decision making, and ideally the impact that has on decision making, kind of like what does it do to the patient more than what it should do or how smart it should be, I guess. Great, I see lots of hands up, and I see Mark Hochberg. It's the Bloomberg School of Public Health. That's for Anthony, I think. It's David Mann says, is AI empathetic, or does it merely pretend to be? It seems at least good at pretending, and I think that's answered. What's the legal term? Like answered in your question?
Well, I mean, I was a philosophy major. Yeah, I would leave that to the philosophers. Probably pretending to be empathetic or just perceive. Right? It's all about the perception of who receives the message. But what I didn't show you for the interest of time in that YouTube clip, but you can go back and look at your later in the demo. They also show how they're using it for the EHR in basket, like the patient portal messages, and the actor, sent a message saying, I've got a new grandchild and now I'm worried about catching COVID or something. What do you recommend given I'm high risk? And the draft response, it was like, congratulations on your new granddaughter. That's wonderful. And that's all Chat GPT generated. And it's, whether that's empathy or just pretend empathy, that's where we are.
Yeah, and GPT is like, their responses are twice as long as doctors also, notably, I think. So Michelle, I saw your hand up first.
Yeah, thank you. Nice job to both of you. This was really informative and well done. I have a lot of questions, but I'm going to aim to keep it brief so others have some time as well. You all made the nice point that the end game here is to improve clinical outcomes. Like that's the ultimate goal for using these tools. And so I'm curious as to what is the current research landscape on evaluating how well using these tools does help improve clinical outcomes.
I think that's it. Katie just answered.
I mean, so again, because this is all industry developed and held so close to the vest, we can get, there was a National Academy of Medicine where an EPIC representative presented in the fall, and you hear these tidbits where they're doing A/B randomization of some of these like clinical summarization tool where they'll, randomize some providers to getting the tool and others not in their clinical testing sites around the country. But for those who are not in those sites, but that's all EPIC designed, right? Like it's not like there's FDA coming in and saying our standards for trial testing or base of evidence for clearance of a device are X. No, it's sort of whatever you want it to be right now is the standard. But that's an area that Dan and I and Anthony and others have talked a lot about, that we really see value and a need for bringing sort of epidemiological principles around like pragmatic trial testing, and how would you actually design a high quality trial around these tools pegged to real clinical outcomes. And we think that there's definitely a need for research there and methods-based research.
And JAMA, like this week, the same time we had a viewpoint published, it had another viewpoint saying like, we need clinical studies basically. And the person didn't really say how those were going to happen. They said maybe there should be a new institute to study this or something, which it felt kind of vague, but I do think that's a real question, especially since a lot of this may be deployed like parts of the electronic health record have been deployed, which is, hey, it's here, which places are going to use it. And we won't really know what works better or not.
I use executive privilege to just chime in that point. I mean, I think from a departmental point of view, the issue is can you infiltrate the advisory boards at places like Epic relatively quickly? And I think Dan's last point is really correct, in that a lot of the time the electronic healthcare records have done terribly poor jobs of rolling out new products, and then you have no idea what's working and what's not working, because they haven't had the right people of how the rollout can affect basically the analysis. So we're trying. I don't know if we can do it. It's such a hot topic that a lot of the time, I mean, not surprisingly, these major companies want to partner with Harvard and Hopkins and, the biggest names, and not necessarily the people that, how to basically know how to evaluate new products.
Thank you.
Great. I see a few hands up. Soren?
Yeah, that was a great talk. I really enjoyed it. You asked what academia can do, and I think the answer is Cartesian doubt. I think we should be the skeptics in the room. All the rest of the world is running after the money, seriously. There's no doubt about it. The revenue potential here is so huge that everybody are blinded by it. And I think you are wrong, Dan, when you said maybe we don't need to understand how it works. I think we need to understand exactly how it works. And I think we need to understand the limitations to what large language models really are. There is no empathy and there is no intelligence. I mean, they are all contextual, and it's important to understand that. It has been shown that the data you mine are biased against minorities. It tends to be approximately correct most of the time. We should not be interested in the 67% of the diagnosis that the AI gets right, even if the 67 is more than what human doctors can do. We should be interested in when it goes wrong. We should be interested when good human intelligence would have been pulling the emergency brake. I won't trade in my personal physician for any kind of large language model. I can tell you that much. And you can.
I should correct. I want to hear everything as you said, but I should.
It will come whether we like it or not. I'm not fooling myself, but I think our job in academia is to do research, just as if pharmaceutical companies have exaggerated claims about what a new drug does. Then we will say, okay, show us the data. And I think we should do exactly the same here.
Yeah, no, and I agree with you completely. I mean, when I said like, I don't really care about the nuts and bolts of how the model is created exactly, because I don't know if I can predict if BARD is better than GPT-4 based upon like how much, what they consume to make it, because I feel like it gets very complex and I'm not sure really what they actually did. But just the outputs are what I'm very interested in. And I think especially where it goes wrong. I mean, that's one of Katie's ideas, was trying to find like an ontology of error or something, like, what are the errors that happen and how do they happen and when do they happen and how can we be prepared so that they don't surprise people? And of course, like, actually, you need to actually have it running so you can figure out what that is. Yeah. But I mean, it is awfully interesting too that there just aren't that many people studying in this area, especially for the kind of clinical decision-making type stuff, just because I think companies are pushing it ahead, but like, there's like, there will be a space, I think, and a need for people figuring out how you do clinical studies to evaluate, and not assume they work, but, try to figure out, and especially figure out when they don't work and how you could mitigate that. Great. I don't know, see, Clay?
Yeah, maybe I have a briefer question. I'm wondering, is the large language models going to supplant or subsume natural language processing?
So we're probably over time. I don't want to bore everyone, but the short answer, I'll take that one because I think it will not. So I am pivoting. My K is on NLP for reasons I won't bore people with. I am now going to do my work that I was going to do at Hopkins on validating an NLP model, instead evaluating their LLM to do the same information extraction. It is more sophisticated. It will require smaller training data than NLP, but why NLP could still be useful is that if you do a simple classifier, it will not embed PHI in it. So you could actually share that across institutions. You cannot share an LLM that you have tuned to extract information on long-term care facility exposure, which is what I'm doing across institutions. So there will still be a place for NLP, I think, but it is less of a place than it was a year ago.
I mean, and it's interesting for data collection too, that like, even if it's an LLM behind the firewall, like you couldn't say like, show me all patients age 50 to 60 who had this. Like, will it be able to summarize all the data, or is it just trained on all of them?
It could probably do it well, but I think this is another area, figuring out how do you do that in a valid, because we will be moving to a model where instead of building a model and then externally validating at other institutions, which has sort of been the paradigm to date, it's going to be each institution that has their own LLM locally tuning it and having to validate it on an ongoing basis in their local data. And that's a very different methodological process. And it needs epidemiologists to weigh in on how to do that well.
David, man, I see your hand's been up for a long time.
I'm trying to think from the perspective of a clinician. I'd want to know how it thinks in order for me to trust it. And since this is all kind of a problem-solving method, how did it get taught, or how does it learn, or does it search the internet in a nanosecond to figure out which problem-solving solution method do I apply to a particular problem I've been presented with, like the clinical case of pre-test, post-test, after the stress ECG that you presented? I mean, how does it know how to do that?
I mean, it's interesting because we don't know, right? I mean, actually, like you can prompt it and it may tell you like Bayesian formulas for doing it, but yeah, we don't know actually how it reasons these things, right? Like how it thinks through, and and I think that it's funny. You sound like an ID doctor, where like, oh, if we just know the mechanism, we can figure out the output. Which I've just been a bit of a skeptic of that, but I do think it is important, but especially to figure out the output. And there's evidence that these LLMs may change over time. Even the same one may give less good answers, like
Especially as
GPT.
its inputs become LLM
It
generated.
starts
Like if it
self-feeding
starts
it. Yeah.
learning on notes that were itself summaries generated by LLM, there's probably going to be a degradation of performance. Like we're already seeing that in other content. Yeah.
I mean, my experience is if you apply the wrong method to the problem, you get the wrong answer. And so I want to make sure the thing knows how to apply the right method to the problem. And how do I assure myself of that? That's my question.
Yeah, no, I mean, and a lot of it is the companies control all of like how it works, but like you can kind of control what you put in and look at what you get out.
Yeah, and I mean, traditionally, that's been a place where regulators, often FDA, play that backstop role to help assure that something is that we're just playing catch up here, or maybe they will never play a role for certain applications like we've talked about, but that there's someone needs to be playing that role.
Right. I see an interesting comment from Michelle, like this sounds like behavioral economics, where there's thinking about where humans versus algorithms perform better. And I do think behavioral economics is something we think about a lot, because it's sort of like where are the nudges and framing that can happen with accurate summaries too. So that's a great point. And John brings up, is an LLM just a mirror that will reflect and reinforce bad practice, which I think is a realistic concern. And I mean, I think we've seen that already with some of the racial biases and stuff, that it kind of looks like the way general culture is, or medical culture is. It's not better than that. Yeah, so Lori Anderson, I see you've had your hand up for a while.
So I have a question to pivot on the research side of things. How do you think this will affect researchers who, let's say we use large Medicare claims data, right? But we know a lot of times that if you're hospitalized, they might have to code things a certain way to be able to keep you longer because insurance won't pay for it otherwise. How does something like this and this type of data affect researchers, and how accurate can we count on it to be to collect that data? And just like you said, the more it's done on its own, there's possible degradation of data. So how do we pick out keywords? How do we allow ourselves to believe it, and then try to convert that into population health measures?
I mean, and say that nuance program we were looking at, where like it generates a note, it can probably generate billing codes, and you can probably say generate billing codes that pay the best.
So, I mean, I will say, like, exactly as you say, being skeptical of always having your feelers up of when you're using claims data and knowing the potential for upcoding, and how that though, unfortunately, is something that's been, so 3M, actually my mentor at College Park for natural language processing, he sold a company he developed 10 years ago to 3M that uses natural language processing for claims. So that's already been in effect at many hospitals around the country for a decade or more, of basically scanning the notes to identify the most profitable billing codes to attach to the encounter. So LLMs may do this better than that technology, but I think it'll still be a continuation probably of some of the challenges we've already been facing when working with claims data. I think the larger, well, correct me if I'm wrong, like Medicare, the large Medicare claims data, they don't normally have unstructured notes and that type of data in their data sets, do they? Or
it's not something I have a great deal of experience with, so I couldn't swear to it. It's not something I've used, the unstructured.
Okay.
I think that's more from like the EHRs.
They don't have unstructured data.
Okay, so I think we'll actually not see as many applications of LLMs and generative AI in those types of large databases. That's more of the predictive AI, predictive model, because all of that data is what's called structured, but it's the studies that are pulling from the raw or unstructured EHR based data, the notes, the things that are free text, where a lot of the the challenges around LLMs will arise.
I think that's what I was getting at. Maybe I just didn't say it clearly enough. I'm saying that the people that do large claims data now, the shift in research may now go into these LLMs and NLPs. And so that's what I'm saying, like, can we count on that data being accurate if it's now shifting research into pulling data out? Or do you think we're going to see trends in higher diagnoses of certain things, lower diagnoses of certain things because
I mean,
of
it
what
would
it's
depend on
using?
how widespread they are and how much they're applied to billing.
Yeah, I mean, if I was putting on my epi hat, which is my hat, what I would immediately think of, what are the possible biases that creep into the data if the higher resource institutions are using more sophisticated technology for generating high revenue claims codes? And then how does that perpetuate more structural inequities, possibly around hospital level character when you're analyzing claims data, knowing you may get this upcoding that's more sophisticated in certain institutions that were higher resource and have this technology versus other ones that didn't, and that could exacerbate disparities you see in when you're analyzing patient level data. But
I agree. I think, and I'm going to let you go on to the next question, but I think that even opens the door more to the inequities that we see between racial biases, between rural versus metropolitan area biases. But I know there are other questions. So thank you guys so much. It was a great talk.
Thanks. I saw John Sorkin, I know, has had his hand up for a while, or did you have?
Yeah, thank you. There are two things that people often knock about AI. And one of them is that the algorithm used to produce a result is opaque. And the other is that it does not quantify a probability. And I think on some level, these are excuses that we use to ignore these new models. Because if you think about a clinician's reasoning is also generally opaque. It's going to be very rare that you can ask a clinician, please tell me how you decided that I have pneumonia.
Yeah.
Sometimes for simple diagnoses, they'll be able to tell you, but for complex, usually it's just a gut feel. The other knock that people use is that these AI algorithms don't quantify the probability of a disease. Well, guess what? Neither does your physician. So for me, the potential great leap that these AI algorithms can give us are two. One, document the process by which the AI algorithm got from input to output. And two, to quantify. And I think if we can get AI to do that, it will be a major improvement to medical diagnosis and, in fact, many different things beyond medicine. But I'm wondering what the two of you think about my thesis.
John, I feel like that's the most positive statement I've heard from you in a long time. No, you're like me, but more skeptical, I feel like, in certain things. I mean, one thing that's interesting about quantifying probabilities is Adam Rodman, who's a colleague who's been working on this, he did that paper where they looked at New England Journal CPCs. And they actually managed to, like, they had to ask GPT like in 3 different ways and say, this isn't for real medicine, etc. And it would give a probability. So they actually like managed to figure out the prompts to get it to give a probability, to give a differential diagnosis of the top 5 diagnoses and the probability of each. So it is capable of doing that. It tries to suppress it. It tries not to give it. I'm not sure if it's like worrying about accuracy or worrying about like regulation or other things, but it is capable of doing that. And I can imagine models that are built specifically for certain tasks would do it better.
Yeah, and I guess I feel like in some ways, I think, well, no, I mean, I'll regret this as soon as I say it, but in some ways, I think generative AI raises less of those concerns for me than predictive AI, like the deep learning, like the artificial neural network that, you know, like the brain, you have these multi-layer that are taking inputs and outputting a prediction, and we really have no idea what's going on under the surface. And there's been lots of spiritual discussions of at some point, you know, there have been attempts methodologically to increase the explainability and the transparency of these models, but they're sort of hitting a limit where sometimes for images, for example, they really believe there's just not going to be the ability to fully explain why it flagged this pixel in the image as potentially indicative of a cancerous nodule. And some have even argued that these ad hoc, like post hoc methods to explain, what were the most important predictors in the model actually are giving us a false sense of explainability, and that maybe we really need to confront that's just not possible. And if it's demonstrated to work well in other applications, we just ultimately trust that. With generative AI, I mean, like if we take clinical summaries, at least, we think the way these will be implemented is that they'll have hyperlinks to like the summary, and then it will hyperlink to the underlying transcript or the documents and things. And so in some ways, there's more transparency in that of how the model took the inputs and generated its summary output. And that's one of the reasons that we think they would pass one of FDA's criteria for these things being somewhat transparent and explainable.